Hello! Today we're going to be studying the cardiovascular section of the AANP exam board certification for nurse practitioners. So let's get ourselves situated, let's get ourselves ready. Don't forget your chips, of course, and your hummus. Anyway, so there are only 4 murmurs, okay, that you have to know. This is a little bit of abbreviation of all the murmurs. The first one is MR, which is mitral regurgitation. AS is aortic stenosis. MS is mitral stenosis. And AR is aortic regurgitation. So now, to remember which ones are systolic and which ones are diastolic, there is a mnemonic for that. I did not come up with this mnemonic, okay? Don't bite me, okay? It is Mr. ASS and Miss ARD. Okay? So anyway, Mr. ASS, MR stands for mitral regurgitation, AS stands for aortic stenosis, and the last S there that's bolded stands for systolic. So this is telling you that MR and AS are systolic murmurs. Does that make sense? And Miss ARD, MS stands for mitral stenosis and AR stands for aortic regurgitation. And then the D at the end is telling us that these two are diastolic. So MS and AR are diastolic. And MR and AS are systolic. Okay? Hey, listen, it works. It works. You're going to remember it. Watch. So the next section we'll be talking about is what differentiate these murmurs from each other. So you need to know that the systolic murmurs are the only murmurs that will radiate anywhere. So Mr. ASS are the murmurs that will be radiating to places, okay? The MR will radiate to the axilla, and the AS will radiate to the neck. Okay, it might be on the test something like an example question is you heard a murmur and this murmur is radiating to the axilla. What murmur could it be? Well, MR. It could be MR. Okay, so a little bit about MR. It's harsh, it's hollow, systolic, pansystolic. It's heard at the 5th intercostal space, aka the apex. So because if you think about it, it's mitral MR. So it's close to the axilla. So think about it radiates to your axilla. AS is softer, more rumbling sound, and it's heard while the patient is leaning forward or sitting up. And it's heard best on the right 2nd intercostal space, okay? And it radiates to the neck, because think about it, it's closer to the neck. Okay, it's the 2nd intercostal space, so it's closer to the neck. Diastolic murmurs are always bad. They're not benign, they're bad. You gotta investigate. Regurgitation is usually loud. Okay, when you hear in the test, they're gonna describe for you the type of murmur, and then your job is to distinguish what is it, what kind of murmur is it. So when they say it's loud, think regurgitations. Regurgitations tend to be louder than stenosis. And every time you hear mitral, think about the left side of the heart. Every time you hear aortic, think about the right side of the heart. Okay, so if they say it's heard on the right side, then they're talking about the aortic stenosis or aortic regurgitation. If they're saying, oh, it's heard on the left side of the heart, then they're talking about the mitral regurgitation. So now the last section here is about the murmurs having different levels. So they're going to tell you what level is this murmur. For example, this murmur was heard with the stethoscope off. The stethoscope is not even on the patient. You can hear this murmur. So this is 6, okay? This is the loudest, okay? The second one is you can hear it with the edge of the stethoscope. That's level 5. And then when they say the word palpable thrill, that's your level 4. And then 1, 2, and 3 goes like this. It goes like soft, mild, and loud. Okay, so these are your 6 levels of murder. Remember these words because they might pop on the test telling you, oh, which murmur do you hear? What level is this murmur when it has a palpable thrill? Well, it's level 4. Okay, stuff like that. That's it with murmurs. We're done with murmurs. Okay, moving along to warfarin and INR. So a lot of things here to remember. What's the goal for INR for patients with AFib, DVT, and PE? Well, it's 2 to 3. Okay, that's the goal for patients with these type of diseases. And now what's the INR goal for prosthetic valve? Well, that one is a little higher. It's 2.5 to 3.5. So keep those numbers in mind. You can only reverse Coumadin and give vitamin K if the INR is over 5. You don't go around reversing Coumadin all the time, okay? If INR is 3 to 5 and patient is on warfarin, then you got to lower the dose of the warfarin. Why? Because they already reached their goal. If the INR is 5 to 9 and the patient is on warfarin, then you have to stop the warfarin and reverse it because it's higher than 5. So do you understand this? If it's at goal but a little bit high, that's not a big deal. You just lower the dose of the warfarin. But if it's over 5, that's when you have to stop the warfarin and start reversing with vitamin K, okay? So remember that. They're gonna try to ask you these questions on the test. You gotta remember what to do with warfarin. When a patient has their first DVT, you prescribe warfarin for 3 to 6 months. If the patient has a recurrent and multiple DVTs, then that's when you prescribe warfarin for life, okay? If you start patient on warfarin, you gotta wait for 1 month and then check their INR. You don't check their INR right away, okay? You gotta start the warfarin, let them be on it for a whole month, then you check your INR. If your patient is on Coumadin, how often do you check INR? It's every month, okay? It's every month, remember that, every month. Coumadin is every month. Patient need to reach their INR goal in 3 months. That's the goal, is to reach the goal in 3 months. If you had to stop warfarin due to surgery for like 5 days, to restart warfarin, the dose should be determined by the baseline INR and PT. Okay, so you stopped your patient from warfarin because they're going to surgery. Now after surgery, you're trying to resume warfarin. What do you use? What numbers do you use to start the dose? Well, you gotta use your baseline. Just use your baseline INR and PT. Reversal of warfarin is vitamin K. So you tell your patients that are taking warfarin to slow down on vitamin K, eat less vitamin K. So now we need to know what is vitamin K. Where is vitamin K found? You got to try to remember some food that has vitamin K, because these might pop on the test as multiple choice questions of like, which of these food do you have to tell your patients to avoid when they're on warfarin? So when it comes to vitamin K, I have a collection here of all the things that have vitamin K. It almost sounds like a fancy, weird hamburger with too many toppings, weird toppings, and there's fries on the side because potato has vitamin K. And a lot of mayo, mustard, it has soybean oil, it has canola oil, it's very oily hamburger, okay? Now it has a bunch of greens, okay? Everything green. We got green leafy vegetables. You name it. Kale, collard, I don't even know what that is. Spinach, iceberg lettuce, Romania lettuce, even Brussels sprouts, okay? So when you see things that are green, or potato, or some oils, think vitamin K. You gotta let the patient stop eating these things while they're on warfarin. Moving along to heart sounds. Here, I want you to remember this mnemonic also. It's a nice one. It is called motivated apples. Why does this matter? What is motivated apples? What does that have to do with heart sounds? Well, MT in motivated are the two valves that close in S1. And apples, AP in apples, are the two valves that close in S2. That's why it has to be motivated apples, okay? Motivated is MT and apples is AP. MT is your mitral and tricuspid. And AP is your aortic and pulmonic. So here we're trying to remember which valves close at which cycle of the heart. So S1 is your systole, S2 is your diastole. S3, you hear S3 when there's left-sided heart failure or when there's fluid overload in the lungs. It's heard on the pulmonic area. It's normal only if your patient is a child or pregnant or an athlete. Other than that, it's a problem. If a patient is over 35 years old, it's abnormal. It's the other nickname for it is opening snap. Okay, opening snap. S4, it causes left ventricular hypertrophy. Because it's heard when the patient has left ventricular hypertrophy, because the left ventricle becomes very stiff, and it's mostly associated with CAD, with stroke, with MI. Patients who have S4 are sick patients. They have a lot of comorbidities going on. The other name for S4 is atrial kick or gallop. Okay, if the patient is very elderly, then S4 will be normal, because most of the time elderly patients will have stiff left ventricles. And now we're moving on to 3 different other sounds that might show up on the test. And just keep in mind, you kind of know a little definition of these things. So the first one is split S2. This one you need to know that it's benign, okay? And it's normal to hear this weird split S2 during inspiration. It goes away during expiration. It's normal, it's benign, leave it alone. The second thing you need to know, which is not normal, is sinus arrhythmia. What is sinus arrhythmia? It's high heart rate that increase in inspiration and decrease in inspiration. So as the patient breathes, they have, during inspiration, the heart rate is high. During expiration, the heart rate drops down. So that's your sinus arrhythmia. That's the perfect definition for that. And then pulsus paradoxus is low systolic blood pressure upon inspiration. Okay, so as the patient takes a breath, that's the blood pressure goes down. Okay, that's your pulsus paradoxus. And usually pulsus paradoxus is associated with status asthmatics. So when they tell you a patient has asthmas that happen over and over and over, and then you're hearing this blood pressure changes with respiration and all that, you have to guess that it is pulsus paradoxus. That's what they're trying to talk about for you. And then moving along to the bell versus the diaphragm of the stethoscope. The bell ends with the L. This is where you need it to hear low pitch, okay, like S3 and S4. Diaphragm is for high pitch sounds like S1 and S2. Simple. Now, assessing cardiac sound mnemonic, which is my favorite mnemonic, one of my favorite mnemonics. I didn't make this mnemonic either. My teacher taught us that in nursing school, and I'm sure a lot of you might have heard of it too. It's all physicians earn too much. So aortic, pulmonic, Erb's point, tricuspid, and mitral. Okay, you got to remember where your stuff are. You got to remember that's from nursing school. I'm not going to go into details of that, but this is a little refresher here. Aortic sound is heard at the second intercostal on the right. Pulmonic is heard at the second intercostal on the left. Tricuspid is heard at the third and fourth intercostal on the left. And mitral is heard, you know it from nursing school, fifth intercostal space on the left. And it's AKA the apex of the heart. That's where it's heard. And then moving along to hypertension now. Now the JNC goal for hypertension is less than 140/90. And if the patient is over 60, their goal blood pressure becomes 150/90. Now normal is 120/80. We know that. Now when do you say it's stage 1? When it's 140/90. Okay. Stage 2, it's when it's 160/100. So remember your numbers here. Remember 120 for normal, 140 for stage 1, and 160 for stage 2. Remember these numbers. They might show up on the test. Now, how do you distinguish the hypertensive patient's eyes? Okay, think about the silver copper wire. Okay, this word might pop on the test. It pops in a lot of the AANP exam. They tell you you're looking into patient's eye, or you're doing an eye exam, and you see silver copper wire. You also see AV nicking and nipping. Okay, whereas the vein crosses over the artery. And you see flame-shaped hemorrhage, papilloedema. So what are these signs represent? Well, these signs represent uncontrolled hypertension. Okay, so you need to first control the patient's hypertension and refer them to ophthalmology, okay, because these are abnormal findings. Moving along to blood pressure medications now. For African American patients And for patients with severe kidney disease, patients with renal artery stenosis, and patients with hyperkalemia, you do not prescribe ACE inhibitors or ARBs. Okay, remember that. These are the times and the people that you do not prescribe ACE inhibitors and ARBs for. You don't start with that. This is not your first line of treatment. There's a little note there that ACE inhibitors and ARBs, you can prescribe them for diabetic patients or kidney disease patients, but not for severe kidney disease patients, okay? There's a little note there to remember that if it's a severe kidney disease, you don't start with ACE inhibitors and ARBs. For heart failure patients, your ACE and ARBs are the first line of treatment, okay? So you need to remember, what's the first line of treatment for heart failure? You need to think ACE inhibitors and ARBs, okay? If the patient has CKD and diabetic, the first line is ACE inhibitors and ARBs, okay? So your patient is having, this is all the scenarios that I have here. Patient has hypertension and diabetes, start ACE and ARBs. Patient has hypertension and chronic kidney disease, start ACE and ARBs. But if the patient has severe kidney disease, you don't start with ACE and ARBs, okay? So remember that highlighted portion on top, and then at the bottom is the other scenarios that might pop. And then if you have an African-American patient with hypertension, even if they have diabetes or CKD, you have to start them with thiazide. So their first line of treatment are thiazide, not ARBs or ACE inhibitors. Thiazide or CCB, which is the calcium channel blockers. CCB is usually stronger, so CCB if the blood pressure is too high. But again, no ACE inhibitors and no ARBs. So thiazide is the first line for these patients. Moving along now, if the diastolic is over 100, remember that this is considered a hypertensive emergency, aka malignant hypertension. You send your patient to the ER. Now, what is the DASH diet? You got to tell your patients to eat the DASH diet when they have cardiovascular disease. Well, the DASH diet is when your sodium is less than 2.4. Okay, remember that number, 2.4. And eating food rich in potassium, magnesium, and calcium. That's really your DASH diet. Remember that. Chronic and poorly controlled hypertension are the main reasons, the main cause of LVH and stroke. Okay, remember this kind of little piece of information there. If the patient has BPH and also is hypertensive, this is when you can prescribe for them tiorazine or tamsulosin because they are alpha blockers. If the patient has osteoporosis and hypertension, you can start them on thiazide because it stimulates osteoclast. Okay? And now moving along, these are the things you gotta avoid and when to avoid them. So let's talk a little bit about calcium channel blocker. You avoid calcium channel blocker and beta blocker in patients with GERD because they cause heartburn. Okay, you're only gonna make their GERD worse. And you avoid calcium channel blockers with grapefruit juice. And you avoid calcium channel blocker with patients in heart failures because it causes peripheral edema. And CCB blocks calcium from entering the heart. Okay, that's not good. If you have a heart failure, you can't be giving your patient calcium channel blockers. You're going to make the heart fail even more than it's already failing. Avoid calcium channel blocker in metabolic syndrome because also of the peripheral edema. Patients with metabolic syndrome already have obesity and they already have edema going on. You don't want to make that worse. And then you don't give ACE and ARBs to pregnant women, and you don't give beta blockers for COPD and asthma patients. You don't do that. Remember that. You also avoid thiazide in metabolic syndrome patients because thiazide increased cholesterol and blood glucose level. So these are a little bit confusing, but just keep practicing and keep remembering these small pieces of information. And we can now move along to heart failure. So with heart failure, there's 4 classifications of heart failures, 1, 2, 3, and 4, okay? 1 is no limitation of activity. So yeah, a patient has heart failure, but they don't have any activity limitation, they're fine. The second one is ordinary activity results in signs and symptoms of heart failure. And the third one is marked limitation of activity. They really can't continue the activity anymore. They have to stop and catch their breath. And the fourth one is they have shortness of breath and they have heart failure symptoms even when they're at rest, even when they're not doing anything at all. Your early signs of heart failure are high respiratory rate, high heart rate, S3, crackles, lower extremity edema, and weight gain. Focus on weight gain because I remember this was a big focus when I was taking the course for the AANP exam, that the first sign for heart failure is weight gain. So think about that. Now, the right-sided heart failure signs and symptoms are JVD, jugular venous pulsation, jugular venous stenosis, distension, enlarged spleen, and enlarged liver. And then left heart failure signs and symptoms are crackles in the lungs. Remember, left heart failures, lungs, L and L. Remember that left starts with an L, lung starts with an L. Left heart failure signs and symptoms shows crackles in the lungs, okay? If the patient has heart failure, again, you avoid calcium channel blockers. Patient with heart failure also should avoid TZDs, which are your Actos. And patient with heart failure should avoid NSAIDs, okay? Because NSAIDs cause increase in sodium level, which causes even more fluid retention. Think about the sodium. Every time you have a sodium, where the sodium goes, the water goes. So we don't want to give them NSAIDs. Treatment for heart failure, first line, is ACE inhibitors and ARBs. And that's the first section of the cardiovascular. Hope you guys enjoyed it. Hope you learned something new. And stay tuned for part 2. Bye. Happy studying.